Welcome to our live webcast. Thank you for joining us. My name is Jacob and I'll be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of your screen, you will see a Q&A/polling window. There's a large window which holds all of your sent messages and a smaller text box at the top where you'll type in your questions. To send a question, click in the text box, type your text, and when finished, click the Ask button. All of the questions you submit are only seen by today's presenters, and your questions will be responded to in the order in which they were received and will be addressed throughout the presentation. At this point, I'll go ahead and turn the presentation over to our moderator to go ahead and introduce our presenter. Thank you.
We are honored to have Dr. Somani speak for us today. Dr. Somani is a graduate of the Medical College of Ohio and completed her OB/GYN residency at Mount Carmel Medical Center in Columbus, Ohio. She is board certified by the American Board of Obstetrics and Gynecology. Her clinical practice specializes in obstetrics and gynecology, and she has a special interest in minimally invasive surgery along with robotic surgical procedures. Dr. Somani is an American College of Obstetrics and Gynecology Fellow, a past president of the Columbus OB/GYN Society, a member of the Academy of Medicine and the Ohio State Medical Association, a board member of the Santan Perinatal Peer Review, and past board member of the Knightsbridge Surgery Center. She has served as a delegate and alternate delegate to the Ohio State Medical Association. This evening, Dr. Somani will review her clinical techniques as related to opioid-sparing pain relief for C-sections. Thank you all for your engagement and participation. Please help me welcoming Dr. Anita Somani.
Thank you. Thank you all for the introduction. And these webinars are becoming more and more popular and more common as we continue in this world of quarantine and COVID. Initially, I had trouble with it because you feel like you're talking into a blank room. But I guess it's no different than standing in front of an audience and no one's paying attention. So hopefully you all will feel free to interrupt me with questions and comments as we go through so that we don't, keep the questions till the end of the conversation. That way you'll have it fresh in your mind and I will be able to address it based on the slides that we're going through. So my journey to using the ON-Q pump started back in 2011. We had started doing robotic surgeries in 2009. And at the time, we're looking at ways that we could decrease our costs because one of the big things that we were running into was people basically disparaging what we were doing and saying, oh, it's too expensive, this will never catch on. And now here we are 11 years later and robotics is becoming more and more the standard. So when we started looking around at what were some options, we found that the orthopedic people were using the ON-Q pump. Other people were using injectables or tap blocks, different methods for managing pain, but nobody had one great method. The orthopedic surgeons, although they felt very strongly about the ON-Q pump, they felt that it really helped their patients get up and become more mobile. And one of the things that we do know now is that the ON-Q is also being used for rib fractures. One of the conferences I went to, there was a trauma surgeon there talking about how it improves outcomes for people who've had rib fractures. So I think there's more and more uses that we're finding on the ON-Q, but I'm going to obviously focus on what we do in our practice. I do speak for Avanos, as you all know, and I think, again, this is basically educational purposes. Hopefully you all will be able to share this information with the physicians that you work with. And always feel free to use me as a reference. Krista and Joe, everybody on here knows how to get a hold of me, so I don't mind answering emails or taking phone calls. I'm also a researcher and speaker for AbbVie. AbbVie is doing research on drugs for endometriosis and for fibroids, and so that's where the overlap or the intersection comes in because we do a lot of robotic surgeries for those patients, and in order to get them home and get them, out of the hospital quickly, the ON-Q has been a godsend. So my experience, and this was just looking at 5 years between January 2014 and January 2019, I did 380 robotic hysterectomies, 112 excision of endometriosis, and then 76 robotic myomectomies. I had 4 patients that declined the on-Q pump. And our practice, we have at the pre-op visit, we have our nurses go through and show our patients the on-Q pump, explain what it looks like, how it works, and that way they're not surprised when they see it after surgery. And it also gets them more comfortable with the idea of how to take it out. They've seen it, they felt it, and it makes it a lot easier for people to be accepting of it, since it is a pretty new thing for most patients. So the 4 that declined, one of them declined because she was allergic to all of the injectable anesthetics, so lidocaine, ropivacaine, marcaine, all of them. So she could, obviously the on-Q pump would have not served her in any way. However, there are some studies that have looked at using the on-Q with anti-inflammatories, with IV anti-inflammatories. So that may be an alternative for someone like that. But at the time, I didn't really think about it. And then I had another patient who said she was a cat lady and she was afraid one of her cats was going to pull out the pump, so she didn't want to have that in there. And then the other 2, I think, also had various reasons, but basically declined. And we talk about things, but we want our patient care to be sort of a shared decision-making process. So if a patient feels strongly about not having it, I'm not going to force the issue. But when you look at the numbers, most patients, because of their fear of narcotics, are really excited to have an alternative. So this is a typical day in the OR. The pumps are filled by the pharmacy. They bring them in. They're all labeled for the patient. So we have them in the room. So as we turn over, we don't have to wait for the pump to come in. And then the catheters and the needles are all at the bed, are all per patient. So everything's packaged, everything comes in. And for those of you who don't know, the 400 ml ball can actually hold 550 mLs of your anesthetic. So that makes it a little bit better in terms of how long it lasts. The 600 ml ball can hold 750 mL. So the pharmacists know that at our pharmacy, but that's something, again, if you are starting a new program, if you're starting to do that at a hospital, getting the pharmacists on board is really important. It's really key. And having that extra 150 mLs in those balls gives the patient almost another day and a half to maybe even a little bit more, depending on what they run their catheter at, pain relief. So when did we go to doing pain relief for C-sections? Again, oftentimes patients are what drive your clinical care. And I had patients that had had robotic myomectomies, that had experience with the on-Q pain pump as a GYN patient, subsequently became pregnant, and asked if they could have the pain pump. They specifically said, I really thought that worked well. Can I have it for my C-section? So we started with those patients, and then we expanded into using them for our patients that had had previous C-sections, assuming that they could act as their own control and tell us, whether this had helped or not helped, or if it was any different experience. So the other big push, and this has happened across the country, but when I first started using the on-Q pump in 2013 for C-sections, we were just getting into the whole idea of the opioid overdose, the crisis that was brewing, the fact that we had so many narcotic overdoses, and people were understanding that oftentimes that first exposure to narcotics came legitimately through surgery or through a sports injury. And so if we can minimize that initial exposure to narcotics and give people alternative pain relief, we're going to lessen the amount of patients that then potentially become addicted to narcotics. America is unique in the sense that other countries use opioids as a last resort. Oftentimes for pain management, you'll see people using physical therapy and acupuncture and nonsteroidals. And all of those alternative therapies like acupuncture and physical therapy and massage are covered by insurances in other countries. But here in the United States, oftentimes those alternative modalities are not covered. And so we end up prescribing more narcotics just because, and I mean, it's a horrible thing to say, but it becomes cost effective for the patient when they're not having to pay out of pocket for physical therapy or massage therapy or something like that, or having to jump through hoops to get their insurance to cover it. But that also obviously has contributed to this whole opioid crisis, which ironically with the COVID crisis has become sort of a thing of the past. You don't really hear many people talking about opioids and issues with narcotics anymore. So this next slide that we're going to look at looks at the number of prescriptions per 100 people. And as you can see, just kind of glancing at this, there is definitely a difference in terms of where you live and what the prescribing level is. So if you look at the one extreme, the lowest number of painkiller prescriptions per 100 people are, in New York, Hawaii, California, Minnesota, states that have very low prescribing rates, all the way to the other end of the spectrum, which is Tennessee, Kentucky, West Virginia. Ohio's kind of in the middle. We do about one pain prescription per one person. So we have 100 written per 100 people. And then on the other end, you can see that Alabama, West Virginia, Oklahoma, these patients are getting 1.5 prescriptions per person. So that's a huge number. So every year, who is it? And for us as physicians, sometimes the first experience a patient has is with a C-section. That becomes the initial, exposure, and they've never had any other surgeries, and then they end up with a C-section. So out of the number of women that have C-sections, about 4,300 opioid naive women become persistent prescription users following a cesarean delivery. So it's about 1 in 300 opioid naive. And what that means is these are women that have never been exposed to narcotics and then get a prescription. When we were, and I've been practicing for over 25 years, in the past, when I first started in practice, we didn't do narcotics much at all. And then there was the whole push for Press-Ganey scores and pain as the 5th vital sign, and the idea that if pain was not treated adequately, then the patient was receiving suboptimal care. So we went to giving people almost like 30-day prescriptions. And when you're giving people 30 to 40 Percocet or 30 to 40 Norco, the patient assumes they're supposed to take all the pills. It's just like when we tell people to take antibiotics, we tell them, okay, you need to finish the prescription. So there was a lot of that misconception, oh, I've got to take all the narcotics. Well, the longer you take narcotics, then the more likely you are to become a persistent user. So what can we do? So what we know from other studies is that if you can adequately treat the initial pain, whether it's an acute injury or surgical pain, you will have patients that have less chronic pain. For whatever reason, triggering the pain receptors initially then creates a situation that these people often have pain even 6 months to a year down the road. So if we can, and that's where the on-cue pump has been super helpful, because it is essentially anesthetizing the nerves, all of the peritoneal nerves, all of the nerves that are in that musculoskeletal space between the fascia and the rectus muscles. Essentially what we're doing is we're creating a situation where they're not getting that feedback that it hurts. And so they're able to move a little bit more quickly. They're less likely to have chronic pain at 6 months and a year after surgery. So what are the other issues? So as a hospital system, hospitals are concerned about cost containment. They're always looking at what can we do to decrease our costs? What can we do, as far as hospital stays? And since COVID, since we started back to elective surgeries in early May, our patients don't want to stay in the hospital. They're nervous about staying in the hospital. So even our hysterectomy patients are now going home after a 4 to 6 hour stay in our short stay unit or in the recovery in the PACU area. They typically go home, and we've done a combination of the on-cue with our ERAS protocol, and that's helped people to get up feeling a little bit more alert, bowel functions better. They're able to, we take the Foley catheter out right at the end of surgery so they don't have it in when they get to recovery. So all those things have helped. And when you look at this study done in 2013, patients who had opioid-related adverse events were hospitalized 3 days longer. The cost was increased almost $5,000 on average. And they also had higher readmission rates within 30 days. And typically the readmission rates were for things like altered mental status or constipation or ileus or small bowel obstruction. So those are some things that, you know, if you can avoid these types of opioid-related adverse events, you're also going to help your patients feel better and feel more alert and be able to get out and move more quickly. We have at our facility, we have people who do use the PCA pumps, and the nurses are the ones who have told us that those patients really are so much harder to get up and move around. They're drowsier, even though the PCA pump is supposed to minimize the amount of narcotic, it still affects them and they're more likely to have respiratory depression. So we obviously haven't used a PCA pump in years, but what I again like is that it's a localized effect, that the on-cue is literally just affecting the intra-abdominal cavity. Does anybody have questions? I'm going to just stop for a minute.
There are no questions at this stage, Dr.
Okay,
Somani.
great. So 180 million in added costs due to the 4 complications listed there, and then 126,000 added days. So again, if you can get those patients home sooner, if you get them back to their normal activities sooner, you are decreasing not only the cost of care at the hospital, but the cost to the patient. Because most of our patients are, like I saw a patient this morning who had a robotic hysterectomy 2 weeks ago, and I'm like, how are you doing? She goes, and I was just like, are you planning to take, 4 weeks off? What are you planning to do? And she goes, no, I've already gone back to work. I'm working from home. And, 2 weeks after a major surgery, and she felt great. So I think a lot of that, again, is that, those initial days, you're not in a fog. You're able to be more active. You're able to get around, get up and move because you have less pain. So this slide talks more about some of the questions we would get from our pregnant moms. They would be asking as far as, how much are the narcotics going to affect my baby? Is it safe for me to take narcotics and breastfeed? What should I be doing to optimize what my baby gets? And again, very little of the narcotics cross the breast milk, but there are case reports of drowsiness, central nervous system depression, and even death. And again, another area where we run into issues with babies and moms are women who have a history of opioid tolerance or who've been using opioids through their pregnancy, and then the baby goes through withdrawal. So that also is a separate situation that we have to be very cognizant of and very careful of in order to treat the mom, but not affect the baby's treatment and management postpartum, because those babies are going through withdrawal. The neonatologist is taking care of that aspect of it. So with patients who have a history of narcotic abuse or drug abuse, we are offering, and especially those that are in pain management programs that are in methadone or Suboxone clinics, we're offering them the on-cue pump because, again, they're motivated to stay off narcotics. So it's a great alternative for those patients too. So patient satisfaction, again, I kind of briefly touched on that earlier. Initially that was not a big concern, but as we've gone forward, there's a high correlation with global satisfaction of care and always receiving good pain control. Patients perceive that if their pain is managed, that the staff is taking care of them, they're listening to them, they're getting better care than when their pain is not controlled. There was a study that recently came out, and I can send the reference, but it looked at racial disparities for postpartum patients and found that there was definitely a racial discrepancy or significant difference between how pain was managed for Caucasian, non-Hispanic women versus Hispanic and people of color or Black Americans, that those who were non-Hispanic white were getting more pain or were getting more pain meds and had lower pain scores. And I know I'm digressing, but the point being that if we're using an on-cue pump on everyone, we are giving them good quality of care regardless of any racial or ethnic diversity. So I think that's also a good way to think about this rather than what we see in medicine right now, where there are some differences in how maybe Caucasians or white women are cared for versus women of color. So ERAS in elective cesarean sections. And again, the goal of enhanced recovery after surgery is to get people moving, get them back on a regular diet quicker, be able to get them home sooner. So early ambulation, when we used ERAS, 51% of patients were up ambulating very early within 8 hours of surgery. Increase in early diet resumption. So again, 57% of patients would have a regular diet or were eating solid food that afternoon or that evening. And there was a decrease in opioid consumption with the ERAS protocol. So our ERAS protocol includes the on-cue pump. Other institutes, other places have utilized TAP blocks, or they've utilized IV Toradol on a scheduled basis. So, and or IV Tylenol. So it just depends on what protocol you use. But we definitely do multimodal analgesics. So 87% of patients that have success with ERAS are in this category are getting, when we say multimodal analgesics, they're getting IV, for example, during our robotic hysterectomies or robotic cases, they get IV lidocaine, they get a scopolamine patch. Preoperatively, they get Tylenol and Celebrex in the pre-op area. And then they do Gatorade 2 hours prior to surgery to help with bowel function. So length of stay, again, if we reduce the length of stay, and again, if an insurance company says they're going to pay for 96 hours, which is typical 4-day stay, in our world today, in the COVID world, we literally, through March, April, and May, patients were going home typically 48 hours after a C-section because they were nervous, because they weren't allowed to have visitors, because the partner had to stay in the hospital with them. That was our protocol here in Columbus, that whoever was there for the delivery had to stay through the whole hospitalization. So for all those reasons, we saw a big reduction in length of stay, but we also see a reduction in length of stay when we had started using our on-cue pain pumps. By the second day after a C-section, most patients felt well enough and they felt good enough to go home. And like I said, our initial population that we used were patients that had had previous C-sections. So they had kids at home and they wanted to get back to their families. So for those patients, we were able to cut their length of stay. So if the hospital is balking at the cost of the actual on-cue pump, you can talk about the cost savings that we see. So in 2015, and these are just different hospitals, the state, local government versus nonprofit hospitals versus for-profit. So literally the range is anywhere from $1,800 per day savings to almost $2,800 per day. So that's a huge decrease in your costs. And most insurances pay what's called a global fee. So the hospital gets one fee for the C-section or the robotic surgery, whatever it may be, and the post-care. So if a patient stays for 2 days, the hospital is going to make more money on that patient because that's a bed that's been freed up for another day or two. If it's a robotic case and they're able to go home that day, they're still getting that full global fee without ever having to expend the cost of a nurse taking care of them, the pharmacist bringing them pain meds, the cost of an IV, the cost of just nutrition. I mean, all those things add up. And I think oftentimes we look at things in isolation and we think, okay, the pain pump costs this much money, but nobody says, well, how much does it cost for the pharmacist to send the narcotics or to send the pain medicine, or for the nurse to then administer the pain medicine and monitor the patient. So all those things I think are harder to globally compare. So how did things start with on-cue pain pumps? There were, initially there was placement in the subcutaneous space after the fascia was closed. And in that space, there aren't a lot of nerves. So there wasn't a big difference in pain scores, but what they did find was a significant reduction in morphine consumption. So there was still this localized effect of having this continuous infusion of anesthesia. The first pain pumps we used were 100 mLs, and they were passive diffusion. So the patient really couldn't control how much medication they were getting or how fast it was going in. And we had people asking us, well, that only lasted like a day and a half to 2 days. Isn't there something that would last longer? And that's how we got into using the bigger pain balls. So visual analog scores. When you looked at scores 12, 24, and 48 hours after surgery, there wasn't a huge difference. But when you looked at the morphine consumption in terms of how much morphine was consumed, there was a very big difference. So at 12 hours after, a day after, and then 2 days after, there was a significant reduction when patients had the subcutaneous placement. Same thing when you look at patient-controlled ropivacaine instillation after cesarean versus, versus just sterile water. And the pain scores were similar at rest, but when they were up and moving around, people had less pain if they were getting ropivacaine infusions. And those patients requested less narcotics also in the first 6 hours after surgery. So over and over again, all these studies really do speak to the fact that a local infusion is going to be much more effective. Even if the patient doesn't recognize that they have less pain, they're still doing things that suggest they're having less pain. And if you can get your patients up and moving around, that also reduces the risk of a blood clot, a DVT or a PE, as well as less risk of an ileus. So for all those reasons, I'm a big fan of the ON-Q. And ironically, I'd been using it for years before I was asked to become a speaker. So it wasn't that I got paid to use it and that's why I became a fan of it. I actually was using it for a long time before I was asked to be a speaker. So this study looked at ropivacaine versus ketoprofen, which is an anti-inflammatory. And they used it for the first 2 days. They looked at placement above and below the fascia. So below the fascia, there was greater than 50% reduction in opioid consumption and less pain than on top of the fascia. And I think that has a lot to do with the fact that you are closer to the muscle. Some of that is infusing into the peritoneal cavity. So you're going to get better pain relief. And then comparing epidural versus incisional analgesia. And this study was from an anesthesia group. And what they found was that intermittent boluses of 10 mLs of 0.25% levobupivacaine, which isn't available in the United States, but ropivacaine is similar, compared to 10 mLs of 0.125% of levobupivacaine in the epidural space. So that was something that anesthesia would provide either at the beginning or the end of a case. The subfascial provided similar pain relief, patient satisfaction, and the use of oxycodone was similar to those patients who got the epidural dosing. Questions before we go on to the catheter placement?
I do not see any questions.
Okay, so the next couple slides covers the actual placement. And these are what come in a kit. So the catheter kit includes either a 5-inch silver soaker catheter, a 6-inch needle, and then a sheath. And then it comes with a Steri-Strip Tegaderm and a 5 ml syringe. Or if you live in a place like Central Ohio where obesity is a big issue, the 7.5-inch silver soaker catheter with the 8-inch needle and sheath is going to be much more effective in that scenario. So depending on your patient habitus might determine which catheter kit you choose. And then the pump is separately filled by the pharmacist. So that's not actually part of the kit that that's placed on the OR table. And then when we do this, I've pretty much converted to doing single catheter placement for my C-sections, whereas my partner does the double catheter technique. So she's putting the 2 catheters in. And what you'll see on these slides is we were putting them in on opposite sides, but now we put them both in on the same side. So once you finish your C-section, before you close the peritoneal cavity, you kind of make sure that there's no bleeding, you irrigate, you do everything you need to. And then because I'm right-handed, I would put the catheter on the right side. I would go 3 inches above the incision. The closer you are to the incision, the more issues you have with leaking. So if your surgeon is putting it too close to the incision or trying to put it through the incision itself, they're going to have a lot of issues with leaking. So I really encourage people to put it up closer to the umbilicus, avoiding the inferior epigastric vessels, and then watching as you go in. You know, you can kind of lift up on the abdominal wall and follow the tract of the needle. And then once the needle's in place with the sheath, you pull the needle out and put the catheter in. So we'll skip this slide. And then once you've pulled the catheter through, we typically lay it up at the fundus and sort of loop it around, and then strip the TPL sheath out of the body and pull it out. And then we do a 5 ml tester dose just to flush out the catheter and make sure it's working. So the silver soaker catheter, as you can see, has markers on it. It has the initial soaker where the little holes are, and then there's holes up to the 10 centimeter mark. And then past that, we leave that outside of the abdominal